let's turn to the patients that approximately a third, 28 or 30%, who have high PD-L1, where we have competing standards, a few trials. We have the Keynote-024 trial, very positive for across the endpoints for pembro monotherapy, and a response rate about 45%. So it's not quite the majority, but a lot of patients who do very well for a long time. And we have a higher response rate with the concurrent chemo IO trials with pembrolizumab for both non-squamous and squamous. Either would be reasonable. So how do you decide whether to favor chemo IO or single agent for your patient with a PD-L1 of 80%? Charlie?
So I think they're both good options, right? I think the data behind both studies is very strong. I mean, you look at Keynote-024 that looked at pembrolizumab versus chemotherapy for the PD-L1 greater than 50%, and that looked very positive, both for survival as well as response rate and PFS. And then you look at Keynote-189, where even for the subset with PD-L1 greater than 50%, chemo IO versus chemotherapy was superior. What we don't have is a study, obviously, in the greater than PD-L1 greater than 50%, where we can safely say pembro is better than chemo pembro or vice versa, because that study doesn't exist. So I think both answers or both options are reasonable. I tend to favor using pembrolizumab monotherapy alone, just because that gives me other options to go to when and if that progression happens. I mean, patients certainly like the idea of using a chemotherapy-free approach. It's a little less toxic. I know we all are very comfortable with managing the toxicities of chemotherapy and immunotherapy, but it's an easier discussion to have. It's an easier regimen. It's a winner all around.
Yeah, and Huss, can I ask, first, do you agree with that approach? And second, if you do, and your general trend or overwhelming favorite is monotherapy, are there some patients where you would make an exception and be more inclined to favor chemo IO?
So the only way that I've decided to work this into my practice is to look at patient symptoms and disease burden. So clearly a symptomatic patient with a lot of disease burden, I mean, somebody who's lost 30 pounds and they're losing weight right sitting in front of you as you're talking to them, and they have night sweats and they have a lot of disease, it's kind of hard to say no to a 60% response rate with chemo IO. So I think for that patient population, I'm more than happy to do it. On the other hand, if I have a patient, as you said, maybe a little bit more frail, not as much of a disease burden, but clearly metastatic, and I don't think I'm going to lose the opportunity to save the patient, then I think I'm okay with using single-agent IO in terms of pembrolizumab in that patient population. So what I have decided to do in my clinic is to look at these clinical parameters and decide whether I want to use chemo IO versus just a pembro alone.
Yeah, I agree with your thought that I tend to favor monotherapy as a chemo-free approach, one that preserves more options. And one other thing is, if patients are responding, you know what they're responding to, and you're not giving them maintenance pembro without knowing which is doing the heavy lifting and which is coming along for the ride and adding cost. These are both expensive agents, so fine if you need both, but if one of them is really the active one and the other is just riding on its coattails, I'd prefer to know what's the active agent and not have someone on 2 years of maintenance pemetrexed with the potential for toxicities there. I mean, we don't have a lot of experience with years of pemetrexed, and I would not say it's exactly the same as the first 4 months and then, or 6 or 8 months and then moving on. But for patients who have a very significant disease burden, just riddled with it, or active symptoms, or the ones who have doubling of their disease between their initial CT and the ER and the PET scan you get 3 or 4 weeks later at the end of their staging, those are patients where you may only have one opportunity, and I don't want to, basically, if I can't look at them and be completely confident that I think they're going to be a candidate for the subsequent treatment if they progress on that pace over the next 6 or 9 weeks, those are the ones who I would do a concurrent.
Right. I
approach.
mean, the only thing I'd like to raise is that there is a sub-analysis of patients on 024 who got chemo followed by pembro, and it doesn't look like they benefited quite as much. So, I mean, that concept is sort of there. So we do have to be careful how we sort of use the drug. But I think as long as we all agree that a patient who's otherwise eligible should at the minimum get pembrolizumab alone in this patient population, I think things are good.